Very good evening for today to my beloved colleagues for AKT aspirant. We're going to start our class today. Today class will be a little different, not specific system, some technical and very important issues in our day-to-day life practice and important for the exam as well. Not only AKT, it is important now in your OSCE exam also in future, that is the X-rays. And today, we will give you some idea little on common ultrasound as well. It will be an extended feature for you, but not too much detail though, very common one. I hope it will be also useful for our practice day today. So our humble introduction, including our institute, the moral alert as before, we are going to the topic of today. We will start with the chest X-ray. And there are some other common X-rays also we are dealing in our practice, but the priority always this is chest X-ray. So let's move on to the chest X-ray, and you look at that. This is the typical normal chest X-ray. You see what we look at, the trachea from here, then the lung fields, heart shadow, diaphragm, these both angles, including the bony cages of the thorax. And you see that in their angle, there is a scapula also visible. Though traditionally we are telling this is chest X-ray, it doesn't mean only the anatomical chest cavity. The X-ray, the area covered by the X-ray is actually the X-ray, including you see diaphragm, and below the diaphragm, you know, there is a liver, and the left side there is a stomach. So you have to keep eyes towards these as well. And this is the lateral view like this. Retrosternal space, retrocardiac space. This is normal looking. So in general, if any growth is there, this black area will be smaller. Even then, any the vertebral column is there, thoracic part is shown. Some major or gross lesion also will be visible in the bony thorax. That means especially in the vertebra. So don't think only the viscera we are looking as well as the bony cages. Now the landmarks in the radiology. What is the radiologic anatomy? This is pulmonary artery, breast schedule. And if I start from here, liver, costophrenic angle, breast schedule, pulmonary artery, lungs, scapula, clavicle, carina, aortic knob, or aortic knuckle, you say, trachea, again the clavicle, the rib, heart, pulmonary artery. This is the diaphragm, the stomach. So in course of discussion, we will understand what the important issues we will look for. And this is a chart taken from the book, How to Interpret a Chest X-ray. You will read by yourself. I just highlighted some very important areas. In the lung fields, any masses, consolidation or cavitation. And the lung apex also important, behind the clavicle. Again, the same thing. If you come to the hilar area, the hilar should be concave laterally. I'm telling some extraordinary information to you, and these information is usually discussed less before. Diaphragm, no more than 10 ribs should be visible posteriorly above the diaphragm. Remember the rib count, the 10th rib in the posteriorly. And the soft tissues, chest wall, again, in the soft tissue masses, the subcutaneous emphysema also important. Lastly, you can see the bones, already we discussed. Pathologically, abnormally, in the chest X-ray, the lesion will be too white, too black, too large, or abnormally positioned. Shifting of the mediastinum like this. This is the basic thing. We will search any too white lesion, any too black lesion, or any too large lesion. And the position, suppose the position of the diaphragm, position of the trachea, these are the things. So if we discuss to the X-ray directly, it will be simpler to you. Before going to the disease state and the question, let's see the technical quality of the X-ray, especially the chest X-ray, we need to consider these 5 points. Inspiration film taken or not. Look at see. Inspiration, expiration. Usually we will where the radio technician is taking the X-ray and they take in this manner and at the height of inspiration. Sometimes patient cannot hold the air, so it might be difficult sometimes to take the film after inspiration. After expiration, it is taken sometime in unavoidable situation. Patient is lying down on the bed, moribund situation. Patient cannot stand. In this time, usually expiration and position will be the lying flat, not the standing position. Okay. So when the film is taken in expiration, some abnormalities are visible. The heart shadow, you see, heart shadow seems to be bigger. The vascularity, increased vascularity due to expiration, there is extra vascular appearance. Sometimes it confuses us. So the film is taken after inspiration or expiration, it should be known, but there is a tradition of the chest X-ray. That means when we write chest X-ray, if you don't mention also, we have to think that the film taken in posterior anterior view, and it is taken after inspiration. Okay, let's see now. Next point is the penetration, the radiation, amount of radiation. There should be standard amount of radiation to check the chest X-ray, to see the heart shadow, to see the lung fields and everything. We consider too black, too white, already you have heard, when it is possible. If the radiation is a standard one, if radiation is more, the lung will be more black and the heart also will not be too much, not the normally white, heart will not be normally white, rather it will be less white if the penetration is more. So if lung become black more, we can think that there may be hyperventilation, not hyperventilation, rather the expansion of the lung is there, which happen in the COPD. For that, the penetration of the radiation is important. Some small soft tissue over penetration by the X-ray can diminish the picture in the chest. It is also important. Remember it. And the soft tissue sometimes seen in the shoulder area or in the axillary area. Suppose the lymph nodes also sometimes visible by the traditional X-ray. So look at the effect of penetration over penetration or less penetration. You see, this is an X-ray normal. There you see black area. There are some shadows. But when it is taken, you see the right side, the lower both lung fields are hazy. There might be some interstitial shadows, and the heart become more wide than this one. So how to identify the penetration perfectly gone or not? You just look at to the left side. May I request one, Dr. Rashid, be with me, please? Just a volunteer. Can you see any vertebral body through the heart shadow here? Though difficult it is. Dr. Hind also. Can you see the vertebra through the heart shadow that is here?
Yes, sir.
Yes.
Yes. And here?
No.
No. So this is the standard penetration when the vertebrae are visible through the heart shadow with difficulties. But very clearly visible also bad. Not visible also bad. This is the penetration. Remember it. Now the confusion. Congestive heart failure or penetration. You see bilateral shadows. It will confuse us as if we don't know about the penetration. So this is an artifactual X-ray because vertebrae are not visible. That means penetration is less. So more likely this is the problem of penetration, not heart failure. Now the next point is rotation, right and left. So how to measure the rotation or check the rotation? The distance of the spinous, distance of the clavicular end from the spinous process. Look at this. You see, this is the rotation. Patient is moribund. Patient is moribund. You see, this is the rotation. Trachea towards the right, And similarly, in the left-sided film also, it could be the shifting. But if you look at the spine here, if you measure the clavicular end, it is also, you see clavicular end, the spine is here, it is not the
Created to
equal
right
distance.
side.
So both are rotated. But rotated doesn't mean that the X-ray is normal. Suppose there is mediastinal shifting, this is abnormal, plus there might be additional rotation also. So radio technicians are very alert to do this, but sometimes patient cannot stand perfectly. It is also true. And now look at the distorted mediastinum due to tortuous aorta and the rotation. See, again there is a rotation. We have seen, I have shown the picture the previous. There is a rotation. If you look at the, you see clavicular end here, spine is here. So the right side distant is more. It means there is a technical problem. And here, what you are looking is a normal or abnormal, Dr. Hen? Abnormality are you looking here? You see? This is the clavicle, this is the spine. So is a normal distance or not?
Large distance.
Almost normal, right? So there is no rotation. There is no rotation. Now the next word is orientation. AP already I have discussed a little. AP view, PA view, erect posture or lying position. Sometimes we need to know it because lying position will give heart shadow bigger. And sometimes emergency situation by the portable X-ray we have to do it. So this is the orientation. Now come to the picture of orientation. This one and this one. What we are looking in the right side. Dr. Rashid. Heart enlarged. Because this is AP view, AP view. And the PA view, heart is not enlarged. Maybe patient is in critical situation, ICU or CCU. Many wires are there. Even then, heart is not enlarged. But here, heart is enlarged. So orientation, that means the focusing, projection of the ray in from which side, AP or PA. And patient is standing or lying, how the changes become too much tremendous or dramatic. You see, very common. Everybody understand that this is erect posture PA view showing pleural effusion. Even undergrad doctor student also can tell. But in this picture, Dr. Hind, if it is given to the X-ray given to you, will you tell that there is any pleural effusion? No.
No, normal.
Normal. Not normal, a little hazy. Haziness may be there, but it is not pleural effusion. But if you come to know that this film is taken in supine position and it is epi view. Okay? Supine position and epi view. So water is becoming clearly, what I say, going back. At that time, the dense shadow is not there. So this is also pleural effusion. Clear now?
Yeah.
This is also pleural effusion. So we must know the orientation. And the angulation. Angulation means projection of the ribs assume a more horizontal orientation. Occasionally, lordotic X-ray can be obtained intentionally to better visualize the apical area, lordotic view. It is called angulation. Sometimes angulation of the vertebral column also, suppose you know the scoliosis, kyphosis, can distort the viscera in the chest cavity. Okay. And the ribs also, you know, the ribs are initially going down, middle one, obliquely placed, and then again going up. Then you will see the ribs is going, see, from behind ribs are coming and anteriorly it is becoming vanished because there is cartilage only at the anterior part. So, sorry. The angulation also creating the problem. And you see, this is the apical area. This is apical area. What is the difference between this apical area and this apical area? Dr. Hind, can you get any point, any idea here?
Right inspiration, left expiration.
No, no. Maybe both are at the end of inspiration, but identify the clavicle. You see clavicle in the upper part here. Apex is visible, very small area. Crowded bones are there. But here, can you follow my cursor along the clavicle? Doctor?
Apical, yes, area.
This is the clavicle. This is the clavicle. So you see, apical area are bigger. Sometime to visualize the apical area, we need to follow this. We need to follow this. Suppose tuberculosis happened in the apical area. You are suspecting some lesion here, the apical area, but you are not confident is there shadow or not. At that time, we have to advise apical view of the chest. It is called apical view, or another name is lordotic view. So this also should be known, angulation. Okay. Now, example of a good X-ray. Dr. Heen, please read out the point. Inspiratory film, then. Dr. Read one by one. Technical qualities. One is the inspiratory film, then.
Technical quality good. Angle, normal angle.
Okay.
Heart.
Orientation is okay. Rotation is okay.
Orientation, okay.
Penetration is okay. Inspiration is okay. So whenever we get the X-ray, I will identify this thing is correctly done or not. Thank you very much. Now come to that details of X-ray. Chest X-ray anatomy in the lateral view. Already I discussed before. You just make a snapshot, doctor. I will not tell more because you will be given more information also as a link later. Just look at the cardiac diameter. There are other ways also, the maximum point, but in general practical purpose, this point, and the chest diameter from this point, and then ratio. The heart diameter should not be more than 50% of chest diameter. Okay. And here retrocardiac or pre-spinal space and retrosternal space. I have written here, you see, the space should be visible and less than 2.5 centimeter in width. Which one? Retrosternal space. Retrosternal space should be 2.5 centimeter wide. And the retrocardiac can be demonstrated at 0.3 centimeter below the manubrium sterni. That means from here. So if you see minutely to the X-ray, you can get. But usually in our practice, we are not getting the lateral view. But for practical purpose in future, it will be useful for you. We are showing. Now come to your quiz. Abnormalities. What abnormality you are looking, Dr. Rashid? Quickly, no more time.
Cardiac space low.
Huh? What?
Shorting.
What, doctor?
Cardiac space.
Cardiac?
Cardiac space, yes.
Heart there or not?
Shorter.
Short. Heart is short.
Yeah.
That means it's small.
Yes.
Dr. Rashid, everybody please share. What you are looking? Quickly, doctor. Don't take more time. Everyone, what you are looking?
Lips clear.
Huh? No, I'm just asking simple observation, not detail. Nobody getting anything to say.
Position not AB.
Very critically. Is there any heart at all?
Yes, no, heart.
Hmm? Dr. Rashid, be confident. Is there any heart?
No.
No. So it will be the gross observation. There is no heart. Is it possible without heart a person can have his or her life? Where is gone? Actually, it is some artificially, digitally constructed X-ray. So heart is not here. Just to check your attention. Okay. Heart was there, but heart is removed by digital technical, characteristics. Okay. So where is heart? Heart not there. So anything missing in the X-ray? Quickly. Anything missing in the X-ray? Very quickly. Something is not there or something. Don't be very serious. Look at grossly. Grossly.
Right side.
Right side what? Oh, Dr. Hind, check your audio, doctor. Now it is okay. So right side is what? Dr. Abdullah also.
Not clavicle seen.
Clavicle not seen. Only clavicle or other not seen also. It may be clavicle going up here. But what is not seen? Here, shoulder and other. Yes, yes, maybe. So the right shoulder, not visible. This is missing. Here, what is the diagnosis now? Come to the core topic. Everybody tell the diagnosis. This is too what? Sorry, too wide in the right sided upper part of the right lung. What is your diagnosis?
Lung collapse. Right side.
Collapse. Why it is not consolidation, Dr. Hind?
Consolidation lower.
Anybody, please, everybody interact. Time will be gone. We have some other topic also today after the X-ray. Dr. Abdullah telling nothing. What about the trachea, Dr. Hind? Who will be silent actually will learn very less, no doubt. So try to talk if possible. Where is the trachea position?
Deviated right side.
Where right side? Dr. Abdullah, do you agree that trachea is position right side or shifted? Dr. Rashid as well, please. You see how much clearly spine is there, clavicle is there, almost in the middle, not grossly deviated. Is there any air bronchogram within the white shadow? Air bronchogram is there. No loss of lung volume. So this is that right upper lobe consolidation. Dr. Hind now understood. Dr. Hind, clear to you. This one, what is the diagnosis? What is the diagnosis? Shadow in the lower part of the chest. Right-sided, there are three lobes: upper lobe, middle lobe, lower lobe.
Lower lobe, right side.
Right side, lower lobe consolidation. Any other option? Any other opinion? Middle lobe consolidation, not lower lobe. It seems to be lower because it is in the radiologic anatomy. It is placed in the lower part, but it is not lower lobe. So how to identify? There is a rule. This is called silhouette sign. Silhouette sign. Right heart border and the diaphragm, Dr. Hind, which is clearly visible, right heart border or diaphragm?
Diaphragm.
Quickly, doctor.
Diaphragm.
Diaphragm is visible, right heart not visible. So right heart difficult visible or not visible, any shadow attached with this is middle lobe. Okay, doctor?
Okay.
If diaphragm is not clearly visible, it will be lower lobe.
Lower lobe, yes.
It is called silhouette sign. You see, this is the middle lobe, not lower lobe. This is called silhouette sign, like this. And the left side also there is some rules. The lingular and the, you see here, and this is the hard border covered by the lung. This is the lingular segment of the left upper lobe. Possibly Dr. Abdullah having the trouble. Dr. Abdullah, check your audio, please. Dr. Abdullah. Now here, answer. What is diagnosis? Very quickly.
Right side consolidation.
Open your eyes. Dr. Hind.
Too dark. Very dark.
No, this is, I am not asking the dark area. Look at the white area. What is the diagnosis? So too white means collapse consolidation mainly. Upper part, in the lower part might be added pleural effusion, but here collapse or consolidation? What do you think? Collapse. Hind, why not looking the trachea shifting? You have done wrong before and you are thinking the same.
No broncho, air bronchogram.
Air bronchogram is not there, but sometimes in the consolidation also air bronchograms are not clearly visible. It is also true, but it is a very characteristic air bronchogram. And the trachea shifted. So before telling the shifting, we need to look at the clavicular end from the spine. This is the message for you. Otherwise, you will be confused. This is consolidation or collapse. Here, what you are looking and give me diagnosis. Where is the finding? Where is the finding?
Left side
Left
consolidation.
upper.
Left side, left upper, right. So left upper lobe consolidation, left upper lobe consolidation. What is diagnosis?
Balloon effusion.
Yes. Middle and lower.
Middle
Right.
lower, but it is not consolidation, so not middle or lower. You have to say pleural effusion, pleural effusion. Why this is pleural effusion?
Absent.
White, yes. Dr. Abdullah telling that it may be lower lobe, middle lobe, both consolidation. Unusual combination though. But in the white area, if there is a curvilinear line, usually curvilinear line. The shadows are white, we cannot differentiate between the consolidation, especially in this picture. But sometimes water is more means you cannot see the ribs also. If the ribs are not visible, more likely there is water or blood, something. But any curvilinear line, the upper part of the consolidation, more likely this is pleural effusion. And the pleural effusion, massive pleural effusion, usually it push the heart or trachea towards the left. Okay, so it will be a massive effusion. And in addition, there is left subpulmonic effusion. Subpulmonic effusion, how to identify? This is the fundic gas, stomach border, that is surface of the stomach. And this is the diaphragm. In between, a space will not be that much bigger, the white area. Okay, there is a measurement also. If the bigger area means there is a fluid, actually, this is the diaphragm in the lung tissue, this border. And in between, there is a fluid. Usually, it will be subpulmonic effusion. Now, this is lung abscess with subpulmonic effusion. The lung abscess, you see air fluid level, there is a cavity relation. And this one, you see subpulmonic effusion. There is a tent-like, but it is not symmetrical tent. The lateral side, there is a peak. Dr. Abdullah, can you see? Everyone look at, there is a peak. It is not marked here. Here, doctor, here. You see, this is a long area and this is a small area. So if the slope is there more towards the lateral wall, it is more likely this is the subpulmonic effusion. Subpulmonic effusion. Otherwise, they are lung abscess. So I will be rapid for you, and if you don't understand, you just ask me. Okay, we got now a question from your exam. Dr. Hind, may I request to read it?
25 years old male present to GB with cough, night sweat, and weight loss. On examination, he has fever and crackles on right apex. His chest X-ray shown. What is the diagnosis? TB.
Other colleague, please share. If you are not telling, we have to jump. It was a tuberculosis in the apical area, clearly.
Yes.
Okay, and now look at the picture. What you are looking? Here, big heart,
Cardiac component.
and there is a double border, would be on the right side. So this is the big heart, like this appearance is mitral regurgitation. Mitral regurgitation. So left atrium enlarged to the extent that it forms the right heart border. Left atrium causing the right heart border. And the right heart border is here. Left heart border is, see, come here. Due to mitral regurgitation. That much big heart. And you look at the vessels of the lung, Dr. Hind. Is the vessels are more visible?
Yes.
Prominent.
Yes.
Prominent. That means the congestion is there. Congestion is there. Dr. Rashad, what you are looking in this picture?
Hysterocardia.
Dr. Rashid is not telling, Dr. Hind is telling. Another colleague, no comment. No comment.
There is air under diaphragm.
Air under diaphragm. So what is your diagnosis?
Mm. Uh,
But heart is normal. Too black, too white, too large, or position problem. What you are identifying? Too black, under the diaphragm, too black. But any other thing, positional issue, Dr. Abdullah?
Yes, heart position abnormal.
Heart position abnormal, heart going to the right. Is it correct, or we are looking the X-ray wrongly?
This maybe dextrocardia.
Dextrocardia. Dr. Hind, what is your diagnosis?
Dextrocardia.
Where is the liver?
Left side.
So you are only diagnosing the heart condition, but not considering the liver also. If it is the liver in the left side, what is shown in the right side? Is the intestinal coils or stomach? Could be. Okay.
Yes.
So overall diagnosis, what will be? It is only dextrocardia, or we have to say some other word? Situs inversus.
So it's
Anything visible in this X-ray? It's a very, very newborn X-ray. You see, understand what you are looking. And you are getting some bowel sound in the chest. If it is so, what it should be? Bowel sound in the chest.
Hernia.
If bowels are in the chest, weird. But the picture shown is here is situs inversus isolated levocardia with transposition of greater artery. Do you think the situs inversus is there? Seems to be, but heart shadow is here. Heart shadow is here, not clearly, but you see coils are there, liver is the left side. If any opening is there, if hernia, there may be the bowel sound in the chest, some coils went up. But the exact thing is here is isolated levocardia. Situs inversus there, but levocardia is there. Dextrocardia is not there, with transposition of great arteries. Okay, aorta and the pulmonary trunk, there is transposition. Transposition means left to the right, right to the left connected. Okay, so our colleague actually posted in the media and I have collected it. Now here, what you are looking, arrow is given to you. What you are observing here? Important.
space between ribs.
Rib,
hyperinflation.
rib notching, rib notching. What is the diagnosis if rib notching is there? Likely diagnosis?
Okay.
Costochondritis. Metastasis.
It's disease, maybe.
Look at your screen. Suppose only one or two, it may be metastasis, but Dr. Abdullah, symmetrically almost in the left side, right side.
Yes.
Less likely to be metastasis, but is aortic coarctation. There is bypassing of the blood, intercostal arteries are there, and their pulsatile nature of the artery causing this notching of the ribs. So bilateral rib notching more likely, coarctation of the aorta. So in general, this is the very simple things for the chest X-ray. So we took significant time, but it is not enough. For better understanding, we will provide you the link. If you don't have link, you will collect from us. Chest X-ray, there will be another big lectures of the X-ray, including some other things anyway. Now we are going to the abdominal X-ray. What you are looking, Dr. Abdullah, in the abdominal X-ray?
We will see if air under diaphragm.
Oh, you are very always looking the air under the diaphragm. Any other thing?
We will see if there is gases, gas distinction,
Yes.
like internal obstruction.
Okay, anyway, you have seen the gases. Gases usually commonly found in normal person also. Any other observation? Patient having abdominal pain. Not visible, nobody looking anything abnormal. Do you agree with this?
Yes.
Any
Renal
further
card,
observation beside this? If it is a renal stone, is there any other observation? What is this?
ureter. Ureter.
Yes, now. So sometime the calculi may be visible in the both kidneys. Nephrocalcinosis. If the bilateral calcification, it means any metabolic disease, especially hypercalcemia. Okay? Hypercalcemia. And hyperparathyroid is the most likely diagnosis underlying. And here, what is your diagnosis by looking at the picture?
This is enlarged intestine, maybe
Intestinal obstruction,
intestinal obstruction. Yes,
small or large intestine.
I think this is a small, large. Sorry, large.
Why large?
Because sequestration.
These are the sequestration. That means sequestration or hostra?
Small intestine.
Hostration. So Dr. Sama telling this
Hostration.
hostration. Dr. Hind,
Yes.
is it the hostration or something else? You see the shadow is visible from this margin to this margin. So is it hostration or something else?
Hostration season.
It is called valvuli conniventis. Valvuli conniventis. It is a small bowel obstruction. And this is coffee bean sign. Sigmoid volvulus, you see, tire-like. Coffee bean, massively dilated sigmoid loop. It is called sigmoid volvulus. And this is also volvulus, coffee bean sign. It is seen in the sigmoid volvulus. See, coffee in the, you see, like a coffee. Pneumoperitoneum. Dr. Abdullah, your air. What you were telling before, more and more under the diaphragm, pathologically, abnormally, air under the diaphragm. This is the liver. Okay. But here, is there any air visible?
Yes. Air under the diaphragm.
Yes, under the diaphragm.
Yes,
So if you advise for exclusion of the pneumoperitoneum, it is said that chest X-ray is better than abdominal X-ray. Chest X-ray is better than abdominal X-ray. For that, this is a chest X-ray to tell you this is pneumoperitoneum. It's a technical point. And another thing is called the crescent sign. You see, below both diaphragm, crescent sign. Under right diaphragm, free air under the diaphragm. I'm just touching something, doctor, because it is not the radiology class actually, basically. And patient is lying down. If you want to identify the air under the diaphragm, it is not possible. Okay, air will be visible somewhere else, if any.
Anti-gravity. Yes, up.
So air is visible here, above.
Yes.
So the lateral decubitus view showing air in the peritoneum. You see? Can you see, doctor? Clean cut air is here. So this is neoperitoneum. This is neoperitoneum. Free intraperitoneal gases here and here, this area. Chelaidity sign, confusing. Chelaidity. Under the diaphragm seems to be pneumoperitoneum. But you see there is a fold of the intestine. Mucosal fold. So this is intestinal coil. It is not free air. So it is called chelaidity sign or chelaidity sign, whatever you say. Dr. Hind, what do you say? I Arab colleagues, how you say this word? Shilidity might be. Sorry, doctor. Exact pronunciation may not be correct from me. Okay. And this is benign. It is not dangerous thing. Remember it. Okay. So these are common. I think so that if any abdominal X-ray important, in my sense, that was important. Now come to other X-ray of the PNS. It was a common. 2 arrow given. What is your diagnosis now?
Sinusitis.
No, there's different diagnosis, doctor, in the right sinus, left sinus. You have to say, okay, sinusitis, but can you specify this? Which type of sinusitis? Acute or chronic? Which one acute, which one chronic?
Left side chronic.
Left side chronic and right side? Right side acute or chronic?
Right side acute. Left side
Acute.
chronic.
Why this is acute? Quickly, doctor, why acute? There is a air fluid level. Air fluid level and more likely to be bacterial if air fluid level, though
Yes.
not much.
Fungal. Left side
Very clear.
fungal.
This is a chronic mucosal thickening. This might be water. So his active lesion is there. In general, other than the maxillary sinus, you have to look at the ethmoidal sinus, you have to look at the frontal sinus, you have to look at the what else? The sphenoidal sinus. Opening the mouth, you see through here is sphenoidal sinus. For that, the X-ray is done by opening the mouth so that all the sinus should be visible. So acute right maxillary sinusitis with chronic left-sided maxillary sinusitis is the diagnosis. And then come to musculoskeletal X-rays. This is the X-ray of the spine showing what? Symmetrical marginal syndesmophyte. So what is the diagnosis? This syndesmophyte is there. Ankylosing spondylitis. Okay.
Yes.
Ankylosing spondylitis. And then remember the word symmetrical syndesmophyte. So there may be asymmetrical syndesmophyte. Asymmetrical means in one side syndesmophyte is visible. This is not ankylosing spondylitis. That means not primary spondyloarthropathy. It is due to association with other disease process. Suppose psoriatic arthropathy or Reiter's spondylitis. In this situation, the syndesmophyte are not both sided, are not symmetrical. Okay. What you are looking in this picture? Any observation?
Sacroiliitis.
Sacroiliitis. You are not looking the sacrum at all, doctor. How can you say sacroiliitis? Dr. Hind, are you using any glass, doctor?
No.
No, sorry. Where is the sacrum?
Osteoporosis.
Sacrum not.
Osteoporosis.
You look at the hip in the both.
No,
Hip.
no, the hip, yes.
Here,
What you are
Dislocation of the hip.
here you are.
dislocation or fracture? You follow my pen. This is in a smooth line, right, doctor?
Okay.
This is a smooth line. If you come here, how can I make this smooth line? You see already, you see? It's difficult to make in a smooth line from here. You see? Is it a smooth line?
No.
No, it is called Shanton line. Shanton line. This is normal, but this is not abnormal. Means there is a fracture. Here, fracture neck. Can you remember, doctor? Fracture neck, femur neck, Shanton line. And what you are looking? Medial malleolar fracture. Here, doctor, right?
Oh, yes. Very
medial
obvious.
malleolar fracture. What you are looking here now?
Fracture.
Fibula.
Which fracture? Which area?
Fibula.
Lateral malleolar fracture.
Lateral medullary fracture. Lateral medullary fracture. And this is the calcaneal spar. Spar can happen above also, in the back and here, heel spar, calcaneal spar. Patient having the pain, but a spar is not there. More likely it will be plantar fasciitis. But a spar is visible here. A spar is visible here. Now come to other X-ray. This is the X-ray of the skull. What is your observation?
This is Baggett disease.
Paget's?
Yes, I think so.
I think so. What are other colleague thinking differently? Please share. Sun ray appearance, chronic hemolytic anemia, or hair on end appearance, hair on end hemolytic anemia. So look at the 4 picture. What you are confused, how you are confused. This I have shown, right, doctor? In the lower
Yes.
one,
Yes.
hair on appearance. And in the skull, there is some black osteolytic lesion. More likely,
Yes.
this is multiple myeloma. Okay. This is a bigger X-ray. You see?
Yes.
This is the acromegaly. And this one, look at the pituitary fossa. It is disrupted and bigger in this area. Posterior clinoid process is not intact. So more likely this is pituitary tumor. So there are four skull X-ray important. Okay. This is the Paget, sir, Paget, what you said below.
Oh, this is Baggett, the one. Okay.
Now look at this, the picture, the gentle lady, elderly, and this is her X-ray. This is Paget, but this is not Paget. The hair on end appearance. Okay. This is the Paget.
How we can differentiate? Wallahi, they look very same for me.
How differentiate? This is a bony, what I said, the remodeling is there. Bony osteoblastic and osteoclastic lesion is going side by side. Okay. So this is abnormally white, this is abnormally black. You see all the bones are involved.
Osteoclast together.
Yes,
Okay.
together. This is the underlying pathogenesis of the Paget's disease. For that, you are getting little high alkaline phosphatase also in the Paget's disease. So this is the osteoarthritis. Osteoarthritis. Who will read, please? Just to learn. Read it, Dr. Sama.
70-year-old right-handed woman was referred to the outpatient clinic by her general practitioner. Over the past year, she had noticed increasing pain and stiffness in the joint of her hands and was now having difficulty gripping and opening bottle tops with her left hand. On examination, there was a swelling over the distal interphalangeal joints as well as the first metacarpal joints bilaterally. Wasting of the muscles of the thinner eminence was also noted. An X-ray of her hands is shown. What is the most likely diagnosis?
Doctor, utter the diagnosis one by one so that you can learn.
Arthritis mutilans, bilateral carpal tunnel syndrome, osteoarthritis, rheumatoid arthritis, scleroderma.
Question is why it is not rheumatoid arthritis? Someone is to answer.
الage osteoarthritis.
This is unilateral.
What, Dr. Hind?
Age came with the osteoarthritis.
So age is important, right? And look at the X-ray, answer from the X-ray. What is the joint involvement of the hand in the rheumatoid arthritis? If you compare here also. PIP, DIP, wrist joint. But here,
Not
the
involved.
description given, first metacarpal, and distal interphalangeal joint. There is, you see some bony growth is there. You see bony outgrowth. Habbard nodes, Bochard node. Have you heard? Habbard node,
Some-
Bochard node. So this is distal interphalangeal joint problem. Patient also complaining there, elderly patient. And there is no stiffness significant. Stiffness is there sometime, but not long lasting. Usually inflammatory disease stiffness will be more than 1 hour.
Yes.
So clinical picture as well as radiology. And if possible, better if you can remember the picture also, doctor. First CMC means, first CMC, carpometacarpal. Look at, can you follow my cursor? Can you follow my cursor?
Yes, yes.
This one. The first CMC is diagnostic of what? Osteoarthritis.
Wasting of muscle. Okay.
Wasting may be due to the disease or less use. It may be due to any chronic disease.
Okay.
So rheumatoid or chronic disease, osteoarthritis is also chronic disease. Now this is the picture A. Dr. Heen, can you read it for us for better understanding? And everybody be attentive to A, B, C, D. Please, Dr. Heen.
Join your call. Arthritis. 8. Rheumatoid arthritis typically target the carpal and proximal interphalangeal joint of the hand. Metatarsophalangeal joint of the feet, as well as other joint. Asymmetrical pattern.
Maybe Dr. Heen having trouble. May I request other Dr. Rashid? Are you ready to read it? Or Dr. Sama, please. There was problem of the sound.
Okay, patterns of joint involvement in different forms of polyarthritis. In A, rheumatoid arthritis typically target the metacarpophalangeal and proximal interphalangeal joints of hands and metatarsophalangeal joints of the feet, as well as other joints. In A, symmetrical pattern. Arthritis target proximal and distal interphalangeal joints of the hands and larger joints in an asymmetrical pattern. Sacroiliitis often asymmetrical might occur. C. Ankylosing spondylitis target the spine, sacroiliac joints, and large peripheral joints in an asymmetrical pattern. D. Osteoarthritis target the proximal and distal interphalangeal joints of the hands, first metacarpal joints at the base of the thumb, one knee, hips, lumbar, and cervical spine.
Dr. Sama,
Yes.
please continue.
I finished. The other last one was osteoarthritis, lumbar and cervical spine, hips, knees. Yes, I finished.
Okay, okay. I think all of you understood.
Yes, very nice picture actually.
If I ask you now, Dr. Abdullah, can you hear?
Yes, yes.
So this is symmetrical. Don't look at the down. Look at the picture. Picture B. Is it symmetrical involvement?
No, not symmetrical.
This is symmetrical.
Yes,
This is symmetrical.
yes.
From the D.
The symmetrical.
How symmetrical? Seems to
Because
be
it is-
symmetrical,
Mm.
but exactly not symmetrical. If you look at these
Joint of
joints,
the hand.
these joint, ring finger is same,
No.
and the small finger, two joint involved. In the small finger, two joint. Here
joint.
only one joint.
Yes,
Okay,
not
Dr. Abdullah.
symmetrical. Yes.
seems to be symmetrical, but not symmetrical. But this is bilateral. Try to understand the word. Bilateral and the symmetrical word, not, these both words are not synonymous. Okay, doctor?
Yes.
There is a
Not
bilateral
symmet-
involvement, but not symmetrical. Not symmetrical, seems to be. And hip joint, spine, and here you see age again, important factor. What is the commonest arthritis in the world, in the patient? Commonest cause of arthritis?
Rheumatoid arthritis.
Dr. Abdullah, how many rheumatoid arthritis you have seen in your life? And how many osteoarthritis?
Osteoarthritis.
Sorry, osteoarthritis. Yes.
Yes.
Arthritis more.
I hope you got some rheumatologic clue also. Now look at the hand X-ray. Any observation you are getting here? The normal hand X-ray. Normal hand X-ray. Now you see involvement. This is metacarpophalangeal. This is PIP, proximal interphalangeal. This is a distal interphalangeal. So that means that these joints are involved, but distal interphalangeal joints are not involved. This is very typical feature of which disease?
Osteoarthritis.
Rheumatoid.
You have seen osteoarthritis just before the DIP, doctor. This is the rheumatoid arthritis. That means distal interphalangeal joint intact. It means, Dr. Hind, it means,
Rheumatoid arthritis.
can you tell 2 times more, doctor, if you don't mind?
Rheumatoid arthritis.
Another time. واحد مرة.
Rheumatoid arthritis.
Very good. Very good. Thank you very much.
Thank you.
Again, we are showing another diagnosis. Actually, as you are AKT candidate for, I took the class very gently, simply, without taking more time. By looking diagnosis, you will learn. What is this here?
Heel sprue.
Heel sprue or calcaneal sprue. Not a sprue, doctor, spar.
Spar.
Yeah, doctor, I have heard this same word from other Sudanese colleague
Just
before also.
sprue.
I don't know. Everybody is telling sprue, sprue. Sorry, doctor.
Spar.
Spar, spar. So just read it, doctor, for better understanding, doctor. Dr. Abdullah, your voice is very nice. Why you are not hearing last time? Please.
The following reveals the X-ray of 33 years old male.
Volume, check the connection, Dr. Abdullah. Volume is low.
The following
good.
reveals the X-ray of 33 years old male who presents with pain in the heel of his foot. Which of the following conditions is associated with the X-ray, with this X-ray appearance?
Yes. So can you read the name? Yes, ankylosing.
Ankylosing spondylitis, diabetes mellitus, osteoarthritis, pseudo-gout, or steroid therapy.
Why ankylosing this diagnosis? It is called anthesopathy, extra-articular manifestations. So what are the clinical features? Young male patient presented to you. Possibly this patient have back pain also, and the back pain is of inflammatory nature. Possibly we discussed the inflammatory nature pain means in our previous musculoskeletal system disease class, rheumatology class. Okay. So this is a calcaneal spar, including the systemic features. So this is ankylosing spondylitis. This one, Dr. Abdullah, in the hand, what is your observation?
Rheumatoid arthritis.
You're telling the diagnosis is rheumatoid arthritis because
Deviation.
deviation and joint involvement.
Involved by distal.
Involving distal or not involving distal?
Not involving distal. Distal intact.
Oh, good. You see effect of 3 times what, doctor? And
Yes.
3 times, always beneficial. 3 times. Rheumatoid hand, you identified that deviation also, you understand, but just look look at that, distal interphalangeal joint is intact. So this is rheumatoid arthritis. He is my colleague, radiologist. He sent the picture. What you are looking here in the knee joints. There are two pictures. There are two pictures, doctor. Not the same patient, different patient. What you are looking? Scurvy. Doctor, is the same patient or different patient?
Same patient.
Same patient. Sorry, possibly there was slip of tongue. And there are some picture. The features are there. There's some terminology. You see, like a burger, round. There are many issues you will learn from here in the subsequent slide. Scurvy, you see, is a semi-diagrammatic radiologic feature. Dense zone of provisional calcification. Another name is white line of Franco. White line of Franco. This one. Below this, there is a black area. Okay. It is called scorbutic zone. You see ring epiphysis. It is called Wimberger sign. I told you burger, the round one, Wimberger sign. This is called angle. It is called Pelkan spar. Pelkan spar. And elevation of the periosteum, subperiosteal hemorrhage. Okay, scorbutic zone name is Tramerfeld zone. I don't know, have you heard all the words before, Dr. Hind? Dr. Hind, have you heard all the words before?
No.
Before today. So try to remember, it is not very difficult X-ray. Sometimes it's a pediatric X-ray be given to you. This is scurvy, and very fantastic differentiating point will be the rickets. Now at the rickets. So wrist X-ray in the normal child, and the B is the ricket. This is the B. You see, seems to be scurvy, but this is not a scurvy. Okay, metaphyseal, it is called the metaphyseal fraying and cupping of the distal radius and ulna here, cupping. So what is the differentiating point? Look at now, scurvy versus ricket. Left side, right side. So which one? This one? Left side scurvy or ricket?
Left
You see
side.
white zone, you see white zone. And this is the cupping, fraying, cupping. This is the rickets. Okay. Now one patient to you. Dr. Rasha or Dr. Shaza, can we invite any one of you to read, doctor? Maybe he's still busy. Dr. Rashid, please. Can you get connected, Dr. Rashid? Anyway, maybe busy. Also, Dr. Hind, please.
70 years old male complain of acute pain with the swelling of the forefoot.
Forefoot.
What is the forefoot? What is the radiological diagnosis?
Okay. Try to read and give the answer. No need to read. Think yourself. Picture is a little go and up. What is the diagnosis?
I think A.
Calcium pyrophosphate dihydrate crystal deposition disease. Another crystal disease is the gout, right?
Gout?
See, to gout and the gout. There is some other crystal also. See, PPD also one crystal disease, gout also crystal disease. So you are thinking number A. Punched out lesion, and there is a soft tissue shadow. This joint is first metatarsophalangeal joint. Right, Dr. Hind? First metatarsophalangeal joint. There is another name of this arthritis. Can anyone say? This is gout.
Gout.
And it is called podagra. Podagra. for diagram. Acute gout. Well-defined, punched out lesion. You see, punched out in the bone. Okay. Still radiology not finished. So X-ray is over now. I will show you just few minutes with the ultrasound, doctor. And after that, I will talk something more also. Just be with me. This is the ultrasound. Every day, if you are doing your practice, possibly you are seeing this ultrasound picture. And we are reluctant also, and we are looking at the report. But to be more confident, try to understand common ultrasound of the KUB region, kidney, and kidney. This is the renal sinus. This is superior pole of the kidney. This is inferior pole. This is the surface. And the central area is the white area is the medulla, okay, or interstitium. And the peripheral area is the cortex. This is black. Usually, it is not dense, okay. And this is a perinephric fat outside. And this is the pyramid, you know, anatomy pyramid, you see. So this picture actually is tried to be presented here by ultrasound. I don't know, do you understand the ultrasound here or not? Please, if you don't understand, anyone, ask me now. Look at this picture and match this picture with this ultrasound picture. So in the cortical area, this will be the black. So it is shown as the red, but the peripheral blackness is actually this area. This is the cortex. And there is a differentiating line, cortex and medulla. It is called corticomedullary differentiation, CMD. So the differentiation is the normal. That means if differentiation is done, if differentiation is possible, this is normal. If differentiation is lost, that means the cortical damage happened and becoming almost the same color of the medulla or interstitium. Now look at this picture, and this is that one kidney, and picture is done as such. What you are looking? You are looking that left kidney, normal corticomedullary differentiation. This is the cortex and this is the medulla. This is the normal. Try to understand in your picture. In this picture, diffuse enlargement of the kidney and diminished echogenicity, loss of CMD, loss of corticomedullary differentiation, you see, not visible. And the kidney is bigger, this area. There may be inflammation in the kidney and acute problem. Diffuse enlargement means acute problem. So you compare with the normal kidney, you see, is visible, doctor? Can we differentiate it from this picture to here? I think so. So this is the enlarged kidney. This is globally echogenic. You see, whole kidney become white. That means very, very long-lasting chronic kidney disease. White. So there is no point as well to differentiate between cortex and medulla. So totally lost. This is actually the fibrosis. In this picture, what you are looking now? This is kidney. Like this position. What you are looking? You are looking, it is also chronic kidney disease and is hyperechoic. May be difficult to differentiate from surrounding tissue. Kidney is shrunken. Okay, cortex thin, much thin. So cortex is there, the differentiation is not there. You see, differentiation is not there. Just these are some highlights to make your practice easier. And in future preparation, if common imaging like ultrasound be given to you, what you will do? For that, I took few minutes more. Thank you for the radiology class, doctor. I will shift to another one. Do you have any query right now? Doctor, do you have any query? Anyone? No one? Okay. So thanking very much, and give me a few seconds to prepare another one.